nature of healthcare means that sometimes difficult conversations have to take place in hospitals between doctor and patient. A case in point of discussions around cardiopulmonary resuscitation, or CPR. In this short film, Dr. Jim Crawford, an A&E consultant at the James Paget University Hospitals, explains why it is important to have conversations about CPR with patients as early as possible, why the procedure is not suitable for everyone, and seeks to dispel some of the myths surrounding it. But first, what is CPR?
CPR is basically a very invasive procedure. It's quite a major assault on the body. If the heart has stopped or the breathing has stopped, someone does compressions on the patient's chest, pushing very forcefully on the chest at a rate of 100 a minute to try and squeeze a bit of blood out of the heart around the rest of the circulation. At the same time, someone else will put a tube down into the lungs so that we can breathe for the patient. And depending on the rhythm of the heart, we may deliver very high voltage electric shocks to the heart, which cause the patient's body to convulse basically, or we may be giving very high doses of drugs like adrenaline. The aim is to try and restart the heart once it's stopped, and the success rate is actually very poor.
Most people's knowledge of CPR comes from watching actors perform it as part of their role in a medical drama series, but it's not always a realistic portrayal.
A number of studies have shown that the success rates portrayed on television are completely at odds with reality. I think the average for TV shows is about 60 or 70% of cardiac arrests result in a successful recovery, usually to the point where by the end of the TV programme the patient is sat up and talking. In reality, only about 20% of patients at best will survive to leave hospital, and the ones that do may well be quite severely debilitated in terms of either heart and lung function or indeed brain function as a result of the cardiac arrest. When it's portrayed on television, it always looks, I think, generally less aggressive and unpleasant than it does in real life, and it always seems much shorter. In real life, cardiac resuscitation attempts can go on for 20 or 30 minutes before the arrest team have to admit defeat and declare the person has died.
Guidance for hospitals about CPR comes from the Resuscitation Council UK, which regularly updates its guidelines based on legal cases.
It's very clear in that guidance that we should be having these conversations. We should be having them realistically with anyone who's admitted to hospital as an emergency. We don't have to have these conversations with people coming in for planned operations or day case procedures unless we feel it's very necessary. But for anyone that comes in unexpected as an emergency, it is good practice to make a decision about CPR. As I've said, in some situations, the clinicians will be absolutely clear that CPR is the right thing to do if that patient suddenly collapsed. And in that situation, they would simply fill out a form saying the patient is for CPR, and they wouldn't necessarily discuss it with the patient if they felt it was a very straightforward decision. If, on the other hand, they feel CPR would not be the right thing for that patient, there is a requirement for them to discuss it with the patient or those related close to the patient, unless it's believed that that discussion would cause actual harm to the patient. And in most cases, it might cause some distress, but the courts are very clear that we shouldn't avoid these discussions simply because they might be distressing for the patient or indeed for the staff. It's clear that we have to have these discussions to ensure that we find out what the patient wants us to do in an emergency at a time when they're not able to tell us.
Doctors who have conversations around CPR with their patients will of course handle them with sensitivity and compassion. However, as Jim Crawford explains, a busy hospital may not be the best place for these conversations to take place.
But in an acute hospital admission where a patient's come in as an emergency admission and a consultant is doing a ward round of 20 or 30 patients in a morning, it is difficult to, on a ward setting, do this conversation with the amount of privacy and time that one would want. But the guidance is that we should be making these decisions as early as that in the hospital admission. We shouldn't be putting them off because we haven't got the time. And so certainly at times the conversation is, like I say, carried out on a ward setting and with a doctor and a patient who may not have met before. And that's why the Resus Council and ourselves, and in fact I think everyone involved in these sort of decisions, would very much advocate that patients talk about this in advance at a time when they're actually reasonably well, with their own GP or their own specialist nurses or someone that knows them well, rather than it having to occur when someone gets admitted as an emergency.
Conversations around CPR can be difficult for patients, their families, and the doctors involved, but they are conversations that must happen. If the conversation doesn't take place, then the default is to perform CPR if the patient has a cardiac arrest, which in itself can have devastating consequences.
So in that situation, if you were sitting there at your loved one's bedside, you thought they were slipping away peacefully, you were aware that they were dying, but if no one had had that conversation about CPR, it is entirely possible that at the point where the patient dies, a cardiac arrest call would be put out, several members of the crash team would run into the room, push you away from the bedside, and carry out CPR, and that your memory of your loved one's death would be highly traumatic as a result. And it's that we want to avoid. For the patients who would benefit from CPR, we want to check that they would want to have it, and for the patients where it wouldn't work, we want to ensure that they're not put through that sort of indignity at the end of their lives.
You can find out more about CPR by visiting our website at www.jpaget.nhs.uk. Simply click on the Patients and Visitors tab and scroll down to CPR, where you will find an in-depth question and answer section from Jim Crawford. Thank you for watching.